The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
So a pleasant day to all. So I am Dr. Harold Chandison Chu, and today we'll be tackling internal medicine with focus on neurology and psychiatry. So this will constitute a part of internal medicine, and usually it just has a few questions, but there are certain conditions that you need to focus on based on feedback from previous years, because they are also important for your exams, plus the cases that you will see when you go to residency and moonlighting. So let's start first with neurology. So let's start with a case. A 69-year-old man is noted to have chest pain with exertion and has been passing out recently. So he has history of diabetes controlled with metformin. And on examination, he's noted to have a mid-systolic crescendo-decrescendo murmur at the right second intercostal space of mid-clavicular line. So the question here is, what is the most likely diagnosis? So here we have cardiac syncope, most likely due to aortic stenosis, based on the murmur being mid-systolic, and you also have the location in the right second ICS. So if it's left, you would suspect pulmonic stenosis instead. So next question is, what is the best initial diagnostic test? So if you have murmurs and you have suspicion of valvular heart disease, so the best test to do to determine valve characteristics and blood flow would be echocardiography. So to the echo siya. So if this patient's syncope is unexplained and the patient has no heart disease, what is the most important test to do? So the correct answer is tilt table testing. So this is performed to determine non-cardiac causes of syncope. And lastly, if this is hypoglycemia, what is the best initial test? So of course, at the ER level, if this patient presents to you, so you check the blood sugar level. So you can check the RBS. And what is the most common cause of syncope? Again, it's still neurally mediated or vasovagal. So to classify your syncope, first we have to define. So it's a transient loss of consciousness secondary to acute decrease in cerebral blood flow. And causes of syncope are generally divided into 3 categories. So you have the most common is the neurally mediated or the vasovagal. And you have orthostatic hypotension, and lastly would be cardiac syncope. And most of the syncopal episodes will occur from a standing position. That is because when you transfer from a recumbent position to a standing position, there is a decrease in blood flow, cerebral blood flow, so that results in syncope. So from a clinical standpoint, a fall in the systolic blood pressure to less than 50 millimeters mercury or lower will result in your syncope. So these are just some clinical pearls. So neurally mediated syncope is the most common cause. So it's the etiology for a vast majority of cases. And then cardiovascular disease is usually due to structural disease, usually your valve disease or arrhythmias. And it's the next most common. So second most common siya. And then orthostatic hypotension, which is defined as the following. So it's a reduction in systolic blood pressure of at least 20 and diastolic blood pressure of at least 10. So this is an OR. Within 3 minutes of standing or head up tilt on a tilt table test. So madali siyang tandaan orthostatic hypotension. So it's 1, 2, and 3, no, the numbers here. So how do we approach the diagnosis of syncope? So these are three important criteria. So was the loss of consciousness sudden or gradual? Number two is, was regaining of consciousness sudden or gradual? And is the cardiac exam normal or abnormal? So tilt table testing is the gold standard for neurally mediated causes. So it can reproduce symptoms in susceptible patients with neurocardiogenic syncope. So usually these, like what we mentioned earlier, these are usually performed for patients without evidence of structural heart disease. But if a murmur is present, you have to order an echo. So if you're thinking of arrhythmia, you do a 24-hour Holter monitoring. And of course, if there is history of head trauma, head CT scan is warranted. Again, some clinical pearls. What is the most important step in the management of syncope is to first rule out life-threatening conditions. You obtain ECG for all patients in order to detect arrhythmia or even myocardial infarction. And for cardiac syncope, usually it's sudden. There are no prodromal symptoms. So the causes would be arrhythmia, blood flow obstruction from your structural heart disease, and of course, your massive MI, resulting in cardiogenic shock. And patients who have a history of diabetes, who are on insulin, and presenting with transient loss of consciousness, you have to suspect hypoglycemia. Now, how do you differentiate syncope versus seizures? So for syncope, it's usually short duration myoclonic jerks. Usually it's less than 30 seconds. The loss of consciousness is shorter compared to seizure. It's usually more than 5 minutes. Usually you get immediate reorientation. Wala silang post-ictal confusion. And they're both would present with autonomic manifestations and premonitory features. Muscle aches for seizures are usually more severe and they last longer, sometimes even have rhabdomyolysis. Both can present with urinary incontinence, and most of syncope is provoked by emotions or even pain. Furthermore, syncope versus seizures, generalized seizures will usually present with tonic-clonic movements, whereas syncope is mostly myoclonic. And going to the most common cause of seizures, the most common cause is the generalized tonic-clonic. And the most important diagnostic step in seizures is 12-channel EEG. It's like ECG of the brain. So they look at the waves and characterize the waves to determine the kinds of seizures. No? All right. So next is another case. A 68-year-old man presents to the emergency room with right-sided weakness and language disturbance. He's a known hypertensive for 10 years. On examination, the blood pressure is 180 over 100, aphasic with gaze deviated to the left. The motor strength of the right upper and lower extremities are both 0 out of 5. So what is the most likely diagnosis? So the correct impression would be acute stroke, ischemic versus hemorrhagic. And the next best step is stabilize the patient and rule out stroke mimickers. So examples dyan would be loss of consciousness, could be hypoglycemia, could also be electrolyte imbalances, or even syncope or seizures. So these life-threatening conditions have to be ruled out. And then what is the best initial diagnostic test? So you order for a plain cranial CT scan. So it's non-contrast. And what is the most likely artery involved in this case? So remember your patient presented with both motor, upper and lower extremities. And then it's on the right. So most likely it's a contralateral side. So it's the left middle cerebral artery. So later on, we'll show you the localization of lesions based on arterial territories. So what are the clinical features and diagnosis? Sudden onset weakness of one side of the body, facial weakness, language or visual disturbance may occur depending on the territory affected. So again, stroke mimickers have to be ruled out. So that includes seizure, intracranial tumors, migraine and metabolic encephalopathy. So that includes electrolytes and hypoglycemia. So the standard imaging modality to evaluate stroke is your plain cranial CT scan because this could tell you at the onset if it's infarct or hemorrhage. No, lalo na yung hemorrhage, kita siya kagad kasi it's hyperdense. So remember this acronym. So BFAST for balance, eyes, face, arms, speech, and time. So if you see these in your patients, you have to call emergency service right away or bring the patient to the hospital right away. Now, for stroke, there's a concept called transient ischemic attack. So the presentation is the same, but the symptoms for TIA usually last less than 24 hours and they resolve completely. Ibig sabihin, walang deficits, no? Walang residuals. Brain imaging is necessary to determine if the cause is ischemic or hemorrhagic. And ischemic strokes appear as dark areas. So these are called hypodense on CT scan. Whereas hemorrhagic strokes would appear white, it's called hyperdense areas. So this is just a management algorithm. So if you're suspecting stroke or TIA based on the symptoms we mentioned a while ago, you first stabilize the patient and roll out stroke mimickers. Of course, don't forget to check your glucose. Then obtain your brain imaging. 85% will fall under TIA and ischemic stroke. And for ischemic stroke, ibig sabihin there's a thrombus or embolus, you consider thrombolysis thrombectomy. And you establish the cause. Usually it's from atrial fibrillation, carotid disease, or others. Only 15% of strokes are hemorrhagic in nature. If it's hemorrhagic, you have to prioritize lowering the blood pressure and also establish the cause. So most of these bleeds are hypertensive intracranial hemorrhages. So you have to decompress the brain if it's warranted. The second most common cause are your aneurysmal rupture for leading to subarachnoid hemorrhage and others. And don't forget your other bundles of care, which includes DVT prophylaxis and then eventually physical occupational speech therapy. And you have to evaluate prior to discharge planning and secondary prevention based on the patient's other disease. Now, how do you differentiate an infarct versus a bleed? So ischemic stroke is sudden obstruction of the blood vessels of the brain. So it's atherothrombotic or cardioembolic in nature. So you get maximal deficit at onset. So the onset of symptoms is very rapid, especially for embolic subtypes. Kasi nga, bumara na kagad yung vessel, no? Whereas for hemorrhagic strokes, usually hypertensive in nature. It's usually due to sudden increase in blood pressure. And the headache evolves over minutes to hours. Since, di ba, nag-bleed pa siya, so the blood seeps over the brain parenchyma. So you lead to more deficits later on. So classically, since it's a very sudden onset for thrombotic causes, usually the patient awakens from sleep with neurologic deficits. And for the bleed, the most common sites would be basal ganglia, particularly putamen and internal capsule. So this is usually due to a hypertensive bleed. These are just scans showing you an infarct. As we said, it follows arterial territory. So they're wedge shaped and also hypodense, whereas bleeds will appear hyperdense and are more diffuse and less defined in terms of appearance. More so on CT scan, ischemic stroke is dark. Again, it's hypodense. Hemorrhagic stroke is white. It's hyperdense. So contrast CT scan should not be used until a hemorrhagic bleed has been ruled out because the contrast will come out of the vessels and further exacerbate brain injury. Although MRI is more sensitive than CT scan, it's usually not performed in an emergency room setting because it takes a longer time to perform. And most of our patients who have stroke are unstable. So matagal ka dun sa loob ng MRI and these patients are unstable. It's difficult to institute basic and advanced cardiac life support in such cases. So next would be the homunculus of the primary somatosensory cortex. So this diagram just shows us where the deficits would be if you have infarcts. So if you look at the middle cerebral artery territory, you'd see the face, the tongue, swallowing, and then also more of the upper extremities. Whereas if you're here in the anterior cerebral artery portion, it's more a lower extremities compared to upper. So usually language is MCA artery. So this is just a table summarizing different weakness patterns. So if it's anterior, like we said, it's more lower extremity than upper. If it's middle cerebral, usually upper extremity plus language disturbance. If it's dominant lobe, you get aphasia. If it's vertebrobasilar, it's posterior circulation. So you get vertigo, nausea, vomiting, dysarthria, ataxia, and gait imbalance. Of course, ophthalmic artery is amaurosis fugax, no? So loss of vision. And posterior cerebellar, so keyword is cerebellar, it's ipsilateral because the rest are contralateral. So usually ipsilateral face, contralateral body, and sometimes you get vertigo and also Horner syndrome. So how do we manage stroke? So it depends on the cause. If it's ischemic, usually it's thrombolytic therapy within a certain amount of time. Then you give antiplatelets and anticoagulation for cardioembolic causes. So if you have atrial fibrillation, ensure neuroprotection. Sometimes we give neuroprotective agents such as citicoline and of course statins. For hemorrhagic causes, it's usually BP reduction with reduction of intracranial pressure. So you can use mannitol hypertonic saline to decrease ICP. And we put patients on head elevation around 30 to 45 degrees, and we hyperventilate with target PCO2 of 30 to 35 milligrams, millimeters mercury. And sometimes we do surgical compression to reduce ICP, especially if the bleed is very massive. So thrombolytics, again, should be administered within 3 hours of onset of symptoms. But if the time is unknown, please do not give thrombolytics. And it's always prudent to rule out hemorrhagic stroke first, because if you give thrombolytics in antiplatelets, magbe-bleed yon. So aspirin should be started as early as possible once you have ruled out hemorrhagic stroke. And remember your 5H of neuroprotection. So you have avoid hypotension, your hypoxemia, hyperglycemia, and hyperthermia. So usually for sugar, we target 140 to 180 milligrams per deciliter. So in relation to stroke, hemorrhagic stroke, there are also other bleeds that are not intracranial, intraparenchymal. So you have your epidural hematoma, so here, and the subdural hematoma. So the difference is that epidural hematoma is arterial blood and it does not cross the suture line. So nasa labas siya. So it's usually from a skull fracture, from trauma, and is a bleed of the middle meningeal artery. So it will be lens shape, whereas subdural hematomas are underneath, no, it's underneath the dura, so it crosses the suture line. It's usually venous blood, and it will be more banana shaped. So these are just images showing you epidural hematoma. So it's a lens shape, it's lemon shape. So epidural, it's bleed of an artery, the middle meningeal artery. So it will be biconvex or lemon shape. The keyword here is the lucid interval or temporary conscious state after head trauma followed by a rapid decline in function. In contrast, your subdural hematoma will be more present, banana shape. So it crosses the suture lines. And it's a tearing of the superior cerebral veins. So usually you see gradual mental status change compared to your lucid interval. So to remember, subdural, letter B for banana, epidural will look like a lemon with biconvex. All right, so we proceed to the next case. A 60-year-old man presents to the emergency room with severe headache, nausea, vomiting over the past 2 hours. The headache developed suddenly with a 10 over 10 in intensity. Oh, he never had a headache like this before. On neurologic exam, there is notable sluggish responsive pupil on the right. So what is the most likely diagnosis? So this is a case of to consider your subarachnoid hemorrhage. The keyword is a sudden headache, worst headache that is of very first onset. What is the initial best test? Again, for any suspicion of stroke or bleed, plain cranial CT. What is the definitive test to detect the site of bleeding? So it's cerebral angiogram. So kailangan a specific tayo angiogram because this will detect which vessel is bleeding or which vessel ruptured. What is the most common non-traumatic cause? So it's a ruptured aneurysm. And the gold standard for diagnosis, lumbar puncture. So you will see blood in the CSF. So just some clinical features of subarachnoid hemorrhage. It's the acute onset of a severe headache. We call it worst headache in life. So this is a hallmark finding. And you have to exclude head trauma as the cause. So if it's excluded, the most common cause would be ruptured aneurysm. Patients usually present with nausea, vomiting, confusion, and a third nerve palsy is brought about by the expanding aneurysm at the junction of the posterior communicating artery and the internal carotid artery. How do we diagnose? Usually request for a non-contrast CT scan. Once you see the hyperdensity in the subarachnoid cisterns, you can proceed with a 4-vessel angiogram. So it detects the aneurysm site. So if your CT scan is initially negative and you're highly suspicious of subarachnoid hemorrhage, you can do a lumbar puncture to determine blood in the CSF. But you have to do the CT scan first because you want to rule out, you have to make sure that the patient will not go into herniation. So in the CSF, we call the finding of SAH as xanthochromia. Treatment is usually surgical. It involves clipping or coiling of the ruptured aneurysm. And nimodipine, a calcium channel blocker, is helpful to control arterial spasms. And similar to hemorrhagic stroke, you manage by controlling the intracranial pressure and, of course, give seizure prophylaxis. So in line of thought with headache or the worst headache, which is subarachnoid hemorrhage, there are other headaches that are caused by either migraine or cluster headache. So how do you differentiate? So usually migraine presents as unilateral or bilateral with aura. So usually changes in vision, photophobia, hearing, taste, smell, compared to cluster is usually unilateral. It's usually tearing and redness of the involved side, the eye, rhinorrhea, and without aura. So how do you abort a migraine attack? You give sumatriptan, no? So it's a serotonin agonist. And for cluster, it's similarly sumatriptan, and it can give 100% oxygen. But prophylactic therapy differs. You can give beta blockers in the form of propranolol for migraine prevention, but you give a calcium channel blocker, a verapamil, CCB, for prophylactic therapy of cluster. So para hindi matandaan nyo siya, verapamil is a CCB, so cluster is letter C. Now, meningitis also causes headache, but it's due to the inflammation of the meningeal membranes that envelope the brain and the spinal cord. So consider meningitis if there is headache, fever, stiff and painful neck, So remember your neurologic PE findings, your Kernig's Brudzinski sign, as well as your neck stiffness, no? So the most common cause again of suppurative CNS infection is bacterial meningitis. And the common pathogens among adults would include three. So that's your S. pneumoniae, S. meningitidis, and your H. influenzae. So to remember, it's national high school. So N. meningitidis, H. influenzae, and S. pneumoniae. Now, the best initial test is CT scan of the head first. So you make sure that the patient will not go into herniation, and then followed by lumbar tap for CSF analysis. So CSF findings of bacterial meningitis is usually elevated WBC count with a neutrophilic predominance, low glucose due to increased metabolism by the bacteria, and you have high protein. And the most accurate test, of course, would be a CSF culture. So once you've obtained your specimens, don't forget to start your empiric treatment immediately. So please do remember from your pharmacology what are the antibiotics that have a good CNS penetration. So another special form of meningitis would be cryptococcal meningitis. So this is usually common in immunocompromised individuals. So usually, if you have cryptococcal meningitis, the CD4 count is usually less than 100, especially in patients with HIV. So the best initial test is India ink. So this is a form of negative staining that outlines the capsule of the fungi. But the most accurate test here would be cryptococcal antigen, your latex. And the best initial therapy would be a combination of amphotericin B and 5-flucytosine. So these two have good CNS penetration. So now we go to the other neurologic cases. So how about dementia? So dementia is defined as a chronic progressive decline in multiple areas of cognitive functioning. So all patients with memory loss, this is one of the hallmarks of dementia, should have head CT or MRI to rule out a structural cause, VDRL to rule out tertiary syphilis, vitamin B12 levels to check if there's B12 deficiency, especially in Wernicke's encephalopathy, and of course, check for thyroid function because sometimes patients with hypothyroidism will have some mental sluggishness. And then Alzheimer's usually have no focal deficits and usually is exclusively seen in older patients, usually more than 65 and above. And your CT scan will just show you diffuse symmetric brain atrophy. Now, Lewy body disease is a condition that has Parkinsonian symptoms plus dementia. So Alzheimer's alone will not have movement manifestations of Parkinsonism. Now, there's another condition called normal pressure hydrocephalus. This usually presents with dementia, and you have gait disturbance and also urinary incontinence. So, triad siya. No? This is a very classic triad of NPH. Now, how do you differentiate dementia and delirium? So, usually dementia is gradual in onset, it's progressive, it's a chronic condition. Disorientation usually occurs later, and it's persistent, so it's not reversible. Whereas delirium is sudden in onset, it's reversible, and at the onset, there's already disorientation and it's waxing and waning. So delirium is usually from another cause, especially in hospitalized patients, no? So reversible siya. Once you resolve the underlying medical condition, usually delirium resolves. So for dementia, as we showed earlier, the most important risk factor is increasing age. And dementia, the hallmark is memory loss. It's usually irreversible. But don't forget to exclude thyroid conditions, especially hypothyroidism and also neurosyphilis, like we mentioned earlier. So related to your dementia would be movement disorders. So that's Parkinson's disease. So Parkinson's disease classically present with resting tremors and with slow abnormal festinating gait. So this is a classic finding. Underreactive face, no, hypomimia, no, walang expression. But it has intact cognition and memory. So walang memory loss sa part nito. So pag may combined ano siya, Parkinson syndrome symptoms and memory loss, think of Lewy body disease. So Parkinson's doesn't have specific diagnostic test. And if you have mild symptoms, treatment could be anticholinergic agents such as benztropine and hydroxyzine and amantadine. But if you have severe disease, you have to give levodopa carbidopa because levodopa will be converted to dopamine and carbidopa will block the metabolism of levodopa in the periphery. So sometimes if you have psychosis due to levodopa, you add your quetiapine. So these are just outlines of medications used in the treatment of Parkinsonism. So again, it's due to decreased dopamine levels in the central nervous system. So how do you increase dopamine? You can either give its precursor and its blocker in the periphery. You can give enzyme inhibitors that inhibit the breakdown of dopamine, both in the peripheral and your central. So you have your catecholamine O-methyltransferase inhibitors, so that's your capones. And you can also target the monoamine oxygenase type B by giving your selegiline, rasagiline. Now, to increase dopamine availability, you give amantadine. And to mimic dopamine, you can give agonists, no? That includes ergot alkaloids, your bromocriptine and ropinirole. Now, the other conditions that include for peripheral nervous system would include GBS. So that's your Guillain-Barré syndrome. So this is an acute inflammatory demyelinating polyradiculoneuropathy. So it occurs usually 1 to 3 weeks after acute infectious processes, usually GI, respiratory, or even from vaccination allergic reaction, and even COVID. So commonly associated infections would include your Campylobacter and your herpes virus, and adults are more affected with males having a higher risk. So this is a symmetric ascending muscle weakness or paralysis that begins in the lower extremities. So ano bang kamukha niyang presentation? Usually hypokalemia. So the usual pattern may first be noticed as rubbery legs. So GPS has some common physical findings. So it has ascending paresthesia, cranial nerve deficits. You can get dysphagia, dysarthria, facial weakness, even papilledema, and some form of autonomic dysfunction, and in extreme cases, respiratory muscle paralysis. So the most specific diagnostic test is nerve conduction study and EMG or electromyography. And the CSF has a characteristic albuminocytologic dissociation in which there is a markedly elevated protein concentration, but with normal cell count. So treatment for GBS is IVIG or plasmapheresis. So this is since it's an immune condition. In relation to another peripheral nervous system condition, we have myasthenia gravis or MG. So the problem with myasthenia gravis is that there is loss of stimulation of the receptors, no, the postsynaptic receptors, leading to muscle weakness. So in a normal neuron, you have your acetylcholine release from the nerve terminals, and they would bind to your acetylcholine receptor. And that would elicit an end plate potential in the muscle, causing contraction and muscle action. But in MG, you have decrease in the number of acetylcholine receptors. So ito mga acetylcholine dito, nade-degrade na sila. So hindi na sila nakakapag-bind. So wala kang end plate potential and you don't have the muscle action. So this condition is brought about by patients developing antibodies against acetylcholine receptor. So it's an autoimmune condition. So patients will present with weakness. So that includes diplopia, drooling of the eyelids, weakness of the muscles of mastication and dysarthria. So usually classic ptosis and muscle weakness. So myasthenia gravis is associated with thymomas. So what is the best initial test for this condition? So you check for anti-acetylcholine receptor antibodies. Kasi nga, di ba, it's an autoimmune condition. So immunoassay. And what is the most accurate test? So usually clinical presentation and the levels of your acetylcholine receptor antibodies are more sensitive and specific than an edrophonium stimulation test. So edrophonium stimulation test kasi is giving an agent that would improve muscle strength and muscle action. So pag nag-positive kasi sila dito, pwede mo sabihin MG, no? It with specified criteria. So how do you treat? You give acetylcholinesterase enzyme blocker. So you prevent the breakdown of acetylcholine so that it could act on the acetylcholine receptors. So that's pyridostigmine, neostigmine. Patients with thymomas, ideally for thymectomy. Sometimes they also give prednisone because this is an immunosuppressant for an autoimmune condition. But in patients with very severe form of myasthenia gravis, such as myasthenic crisis, sometimes we give patients have to undergo plasmapheresis to decrease the autoantibody levels. All right, so basically we've able to encounter the most common conditions that would be asked in your neurology exam, which is part of internal medicine. Now we proceed to the other part, which is also part of your IM, which is psychiatry. So in recent years, we noticed there have been additional questions pertaining to common conditions in psychiatry. So you're not expected to know the very specifics of each of the condition, but what you need to know is to familiarize yourselves with the diagnostic criteria and also how to recognize all or what are the hallmark symptoms of the condition and what is the cutoff to say that this is the diagnosis. So let's start with generalized anxiety disorder. So generalized anxiety disorder is characterized by excessive anxiety and worry occurring more days than not for at least 6 months. So 6 months yung cut off about a number of events, activities such as work or school performance. So patients have difficulty to control the worry. But if you look at the diagnostic criteria, you should need to have anxiety and worry associated with 3 or more of the 6 symptoms, no? And these symptoms have to be present for more days than not for the past 6 months. So ito nga yung cut-off. So ito yung 6. It includes restlessness, feeling keyed up or on edge, easy fatigability, difficulty concentrating or yung mental blocks, irritability, muscle tension, and sleep disturbance. So generalized anxiety disorder or GAD results in clinically significant stress or impairment in social, occupational, and other areas of functioning. And of course, the disturbance should not be attributed to a physiologic effect of a substance or another medical condition. For example, hyperthyroidism or arrhythmia. And of course, ito nga, it's not explained by another mental disorder. Kasi nga, you can get anxiety also from bipolar disorder or schizophrenia. So now we mentioned schizophrenia. So schizophrenia based on DSM-5 is at least 2 of the following. Again, at least 6 months and should not be a direct effect of drugs or psychoactive medications. So ito naman, more characteristics. So you have delusions, hallucinations, disorganized speech, disorganized or catatonic behavior. These are your positive symptoms. And you have negative symptoms, no? Decrease in emotional range, poverty of speech, and loss of interest or drive. So para madali siyang tandaan, remember your negative symptoms and the rest would fall under positive symptoms. And you need at least 2 for the last 6 months. Differential diagnosis of schizophrenia, if it's less than 1 month, it's brief psychotic disorder. And if there is concurrent mood episode, at least one of them, it's a schizoaffective disorder. So treatment of schizophrenia would involve antipsychotic medications to diminish positive symptoms. So you can give first generation antipsychotics, so that's chlorpromazine and haloperidol. And the more commonly used nowadays are the second generation, so that's clozapine, quetiapine. So these medications likely to be asked in your pharmacology, no? So usually these cause sleepiness and also some form of increased appetite and weight gain. However, there is no consensus on the best medication. So treatment for schizophrenia is best individualized. Now, related to schizophrenia is bipolar disorder. So this is characterized by periods of major depression alternating with mania, hypomania. So bipolar disorder has two forms. It has bipolar 1, bipolar 2. So if you have manic episodes plus hypomanic depressive episodes, one yon, no? Bipolar 1, one manic. Bipolar 2 is just hypomanic and depressive episodes. So what characterizes a mania? Mania means there's abnormal, elevated, expansive, irritable mood. So yun yung mga sobrang hyper, no? And abnormal or persistently increased activity energy for 1 week. So 1 week. So ito yung mga medyo madaling tandaan. Bipolar 1, one manic episode, 1 week. This is just a table summarizing the distinguishing features between bipolar 1 and bipolar 2. So, manic episode, hypomanic episode. More severe is type 1. More psychosis, delusions, hallucinations during mania. And usually, type 2 just has some psychotic symptoms. It's less than bipolar 1. So, bipolar 1, syempre mas aggressive yung management mo. Usually, inpatient management followed by outpatient care. For bipolar 2, hypomania may interfere with daily functioning. But of course, the day-to-day life may not be that significantly impaired compared to type 1. So, this is a mnemonic to determine the features of bipolar disorder. So, dig fast, distractibility, irresponsibility, seek pleasure without regard to consequences, grandiosity, and your fast is flight of ideas, agitations, sleep disturbance, decreased need for sleep kasi nga hyper, di ba? Talkativeness. Then we have your major depressive disorders. So remember the cutoff, 2 weeks. The person experiences 5 or more of the following symptoms, with at least one of the symptoms being depressed mood, loss of pleasure or interest. So ito siya, depressed mood, diminished pleasure or interest. Itong dalawa dapat isa dyan ay present, and then you just need 5 or more of the rest. So that includes significant weight loss or gain, hypersomnia, insomnia, psychomotor retardation, agitation, loss of energy or fatigue, feelings of worthlessness or excessive guilt, decreased concentration or marked indecisiveness, and preoccupation with death or suicide, or even if the patient has a plan or has attempted suicide before. So we use this mnemonic, depressed mood plus SIGICAPS, no? Sleep disturbance, interest diminish, guilt, energy loss, concentration decrease, appetite change, psychomotor retardation, and suicidal ideation. So if you will see the different psychiatric conditions, medyo nakakalito because they have different time cutoffs. At the same time, they have different numbers of criteria that you need to satisfy. So my suggestion to study this is to write, to tabulate the conditions we discussed, and then write down, make a row for the diagnostic criteria, the time period, and the features. So you can use the mnemonics that we identified to help you remember easier. But don't focus too much time on these because likely mga 1 to 2 questions lang naman ito. But it's not bad to be able to familiarize yourselves with the conditions and to between the two, prioritize your neurology because these are more common conditions and also more life-threatening conditions. But mental health is also important. So you also need to know some of the more common psychiatric conditions, no? So that's it. I wish you luck in your neurology and psychiatry part for the internal medicine exam. And I'll see you in the endocrinology module.